Do you have a neurodiverse child? Boy, do I have a treat for you. Hello, this is Dr. Francesca Perepletchikova. Today, I have a special treat for all of us. We have a highly anticipated guest. Sam Steinberg is a clinical social worker from Capital Youth Services right outside of DC, correct? Yes.
Yes.
So she is so highly anticipated because she's here to help us all understand how can we help autistic children. And Sam, am I saying it correctly? Autistic children, not children with autism?
Yes, the autistic community prefers it in that order, right? Autistic, and then the person comes after. Unlike many other things, it's not a disorder. It's not seen as a disorder or something that we're
So
going to fix, right? It's just
exactly.
part of who they are.
So we used to say children with autism spectrum, just like we used to say people, or continue to say clients, a person with borderline personality disorder, with depression, with bipolar, identifying that there's a person who has a psychiatric disorder. Autistic community is saying, wait a second, just because we're not neurotypical, just because we are neurodiverse, why are we treating neurodiverse as a disorder? Are we talking about if it's not norm, it's a disorder? Hello, what's happening here, right? Okay, so
Yeah.
autism is not a disorder. This is a neurodiverse, meaning a person has a different brain. Am I saying it correctly? All right.
Yeah.
Okay. And today we're going to talk about, can we use what we know about psychological interventions to help autistic children improve their functioning, the way that they operate in this neurotypical world. So just because they're neurodiverse, it doesn't mean that they still don't need to operate in a particular way in neurotypical world. Is that correct?
Exactly. We're here to talk about how we have found ways to support these families and these kids.
Excellent. Okay, so my first question is, you, at least in my understanding, the way that I was taught in my graduate school, right? We had different like levels of autism, high functioning, low functioning. So how do we relate to that now? What have we learned through the years? Mm-hmm.
Yeah, so autism is definitely a spectrum, and every person or every autistic person is different, right? And so what we see is that there's support needs in some areas, or more support needed in some areas where there's less support in others. And so it's not like a totality of
Mm-hmm.
high and low functioning all of the time, but we're looking in different areas or environments. Also, we're learning so much more about autism. So we're picking up on it maybe a little bit later, seeing some of the behaviors or uh, just things that we're observing as more normal when we're younger, or there are systems in
Mm-hmm.
place that
Mm-hmm.
kind of
Mm-hmm.
help
Mm-hmm.
naturally. And then as relationships and things get more complex as we, enter puberty and get into, those pre-adolescents, those tweens, we might be seeing things that we might say, oh, all of these things together might actually make sense as autism, right? Instead of this thing here and this problem
Uh-huh.
here and this
Uh-huh.
problem.
Right. And you mentioned to me that there is a terminology wise, autistic child, sub-autistic, right? What does sub-autistic mean?
Right, is that we have a lot of the neurotype markers of an autistic individual, but maybe aren't quite meeting the diagnosis, right?
Mm-hmm.
And so,
Mm-hmm.
or we're not quite meeting it. That doesn't mean that some of these strategies that we have found to be helpful aren't going to help people just because you don't fully meet criteria, right, for the full diagnosis.
Mm-hmm.
So
Mm-hmm.
people, individuals that are neurodiverse or right under, right,
Mm-hmm.
sub
Mm-hmm.
level still
Mm-hmm.
have some of those traits turned on. we have found this can be really helpful too.
And it's very, very, what you're saying is tremendously important. And that, just as you said, neurodivergent means it's a range of things, right? It's a spectrum of things. And when I talked about our supersensors, and I always tell parents, hey, they have a different brain.
Yes.
Right? They react differently. They have very low threshold for emotion arousal. They react very strongly. They have slow return to baseline. On the other hand, all the benefits of being able to read other people like an X-ray, right? Have a tremendous high level of capacity for creativity. They're also very compassionate in between outbursts, right? They're very understanding and loving. And so on top of that, we have a lot of comorbidity with children who are emotionally sensitive, as we call them, supersensors. They also have ADHD, right? Very high comorbidity with ADHD. What is ADHD? ADHD means that the maturation of the brain does not catch up with maturation of the body, and at some point it will. And that's why a child can grow out of ADHD, right? And we have not as many adults with ADHD, and adult ADHD is not as severe as child ADHD, but also that shows different brain, the maturation of the brain. Plus, we see that we can have an 18-year-old supersensor who is at time functioning on a level, developmental cognitive level of a 10-year-old. And this is really there, the impulsivity, the reactivity, not just necessarily stemming from emotional sensitivity, but we also know that their cortical regions, their frontal lobe, they don't mature as fast as that of an average developing child with average level of emotionality. So that's some of the things that I'm talking about when I say they have a different brain. And now the term that you're using, neurodivergent, in many ways may apply to our children who are supersensors. So they are indeed neurodivergent. It's just, again, a spectrum of autism spectrum disorders or whatever functional impairment that you may have because of neurodivergent, right? So all of that is within the spectrum. Am I saying?
Absolutely. Yes, absolutely. Like I have conceptualized that a super sensor is neurodivergent, from the beginning of doing this treatment and learning from you. And, some of our autistic kids are also super sensors, just as
Of
you talked
course.
about, and likely are, right? Because they have hyper and hyposensitivities, just like our, super sensors that are going to interact with their bodies. And we know that all impacts emotions and responding and things like that. So a lot of times if we don't have an autism diagnosis, just knowing and learning about being a super sensor and connecting that to your brain is wired different, right? Like it's who you are, it's the temperament that
Talk
allows
about
me.
validation. There's nothing
Yeah,
wrong with you.
right.
Your brain, you have a different brain that gives you
Yes,
challenges and
yeah.
benefits at the same time,
Yep,
right?
allows
Yeah,
me to get in there with the parents and oftentimes parents find out about their brains and how they're wired differently throughout this process and right some of the things that have they learn help their kids end up helping themselves too, which is really cool to see.
absolutely, absolutely. And when we're talking about this neurodivergence, so to speak, right? The techniques that we use for children who have emotional sensitivity, a lot of the time, kind of cross correspond with what we usually know that works for autistic children, right? Like we know like parent management training, helping parents understand how to, do contingency management and to reinforce adaptive behaviors and things of that sort, right? And so, and on top of that, a lot of children who are supersensors do come in with a diagnosis of autism spectrum, but may not necessarily have it because there's such an overlap between symptoms, right? Super
Or
sensitive.
vice versa, right? Come in with the DMDD
Exactly,
diagnosis
but
and
I'm not
actually are
diagnosed with
autistic.
autism.
Yeah.
Yeah, right. So because there's so many symptoms that overlap, right, including sensory processing issues, their ability to, their not ability, their tendency to get stuck, right, and be very concrete at times, and psychological rigidity and thinking, especially when they're emotional. There are just so many things that are similar. What would be your rule of thumb, if there is one, to differentiate between a child who is neurodivergent and emotionally sensitive supersensor and child who indeed is autistic?
Yeah, I mean, like you were talking about, it's a spectrum, right? So there's those kids that kind of fall right on that line. And right, we really rely on additional assessments, including, neuropsych evaluations from psychologists, other sensory profiles and learning
Mhm,
assessments
mhm,
to really kind of pick apart what is going on. I think just like most obviously when you're doing research, a diagnosis is really important, and we're treating the symptoms and right, the problems, the things that are getting in the way of what they want in their life when they come into our office. And so a lot of those things can be very similar, and so we may see similar things across the board, right? And so I think it's really through assessment, figuring out
mhm.
where we can best support the child and the family, right? Increasing accommodations, adaptive
Ah,
accommodations, not the
mhm.
maladaptive ones that we
Yes.
want to make sure we avoid, right? And increasing also skill, right? Because just because a kid is autistic doesn't mean they don't also have emotion dysregulation. So they may have sensory meltdowns
Interesting.
and
Mhm,
they also
mhm,
have emotion dysregulation, right? Because they're
mhm.
human, right? They have emotions.
Already,
So we
already what you
need to
say
go at
is
it at both ends.
absolutely. So already you're making the differentiation between sensory meltdown and emotion dysregulation meltdown, which may look exactly the same. But
And
what
one could lead to the other
and
sometimes.
one can lead to the other. But what you're talking about is what is the function behind it, right? Like as we said, that children who are emotionally sensitive, as children who are callous and emotional, they may look exactly the same in terms of the behavior. They may scream, yell, punch, throw things, right? However, in exactly the same behavioral manifestations apply to how sensitive children respond, callous and emotional children respond, right? So how do you know which one? Look at the
Through
function.
assessment.
Yes,
You
you
got to
need
keep,
to
you got
ask
to keep,
what's the
you got to keep
function.
assessing.
Exactly. So
Yeah, figure
children
out the
who are
function.
emotionally sensitive, the function of this, behavioral dysregulation is reactive and it's coping because they just cannot withstand the intensity of the emotional wave, the tsunami that's overwhelming them. And we all know that when we are very, very angry, what happens? If we scream, we feel a little bit better, like steam coming out of a pressure cooker. And children who are callous and emotional, they don't need that coping. They're not indeed suffering from intense emotions. They're callous, unemotional by definition, right? So what they're doing it for is much more about what?
Getting
Proactive
what they want.
function, getting what they want. This is instrumental function because I learned that it works for me, right? As opposed to coping. So this is reactive, this is proactive, and knowing how to intervene, we can't just look at what the behavior is because we don't match interventions by behaviors. We match interventions by the function of the behavior, right? And we need to know the function, as you
Exactly.
say, assessment, 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 to understand which intervention to use. So for callous and emotional children, they don't need emotion regulation techniques, right? They need problem solving techniques, how to get what they want without using force. While our super sensors do need emotion regulation techniques, distress tolerance techniques, and all of the other things. So intervention by function. So, and I know that you allowed me to call you Sam. So Sam,
Yeah. Yes,
please,
please call me Sam.
please tell me, um, of what we know that works for super sensors, the intervention that I have developed, the dialectical behavioral therapy for children that was specifically developed for emotionally sensitive children, can be applied to other children as well, specifically parent training component. Any
Yeah.
child in this world will benefit from their parents being super parents, whether they have
Yes.
psychiatric diagnosis or not. Any child can benefit from that. So I think parent management training from DBT-C, any parent needs to know. And we actually have
With
this
the validation component so important, right?
validation, how to
Yeah.
validate your child, how to establish a relationship with your child that is based on acceptance, right? On
Yeah.
reinforcement, on shaping, on validation, right? All of this, I think all parents need to know that. And we have a course called Super Parenting exactly for that reason. Now, Sam, let me know what we know from DBT-C for children. We know that it works for emotionally sensitive children. Now, does it work for autistic children?
So in our clinic, we have had a lot of success. And so I have clinical, right, observations and data,
Thank you for
no
underscoring it.
research data.
We have not yet done research on that. What you're here to tell us about is your expertise within the clinical realm, right? So we still
Yes,
do
yes,
research, but this is what you know clinically. So what is it?
yes. Hopefully the research is up and coming.
And do you see a lot of autistic children in your practice, and you and your colleagues?
Yeah, we actually have a pretty high autistic client population. I think it's something that we have really become passionate about in our clinic, and have a few different providers that have really done a lot of learning and specializing in it. And so working together to figure out what's working and what's not, and
Excellent.
our
So you have the
ever-deepening
whole
team.
group of clinicians, not you're not the only one who is seeing autistic children. So there's multiple clinicians within your group that are seeing autistic children, and then you have your, DBT consultation team where you come together and you discuss this and you share your experiences and you help each other figure out what works and how it works, what doesn't work. So the experience, the clinical experience that you're talking about right now, it doesn't just come from you. It comes from the entire team of therapists, correct?
Yeah, exactly. And very lucky we have Sammy Ascanio on our team, and she's working with Lori Ritchell on adaptations to comprehensive DBT for the autistic neurotype. And so really being able to work so closely with her about the adaptation she's making
And
in her
please
comprehensive DBT session.
introduce her to the audience. Who is she?
Sammy Ascanio is a clinical social worker and the DBT director at Capital Youth Services. She's also an autistic clinician, and Lori Ritchell is in
Autistic
North
clinician.
Carolina.
So she herself is autistic person. Oh, wow.
Yes, so has
Oh,
some
wow.
good insight into
Oh,
the
definitely.
sensory, yeah, what it
Oh
feels
my
like.
goodness. That's tremendous.
Yeah. And then she's working with Lori, who's in North Carolina at the TAP program and at UNC. And so they're doing a lot of work about adaptations to comprehensive DBT and DBT-A. And then I'm
For
using
autistic
that in,
clients. And
yep,
now,
for autistic clients.
and
Exactly.
you're working on now adapting DBT-C for autistic clients. Okay. So
Exactly.
your combined experience, your combined expertise, what does it say? How different, how similar, are there the adaptations needed to apply what is empirically supported DBT-C model to autistic population?
Yeah. So what we have found is that a lot of it really is the same, right? It's a parent first treatment. We need parents to be emotionally regulated, skillful super parents, right? We need them to be modeling effective behaviors and loving the kid that they have, right? That is utmost important in understanding the kid that they have, right? And so the basic premise, and understanding of DBT-C and how important that is, that does not change, right?
Parents first.
What
You need
parents first.
parents first. You need to learn how to parent your specific child. All children are different.
Yeah.
When parents come to me and say, okay, one of my child is fine, the other one is climbing walls, I don't know what I did wrong because I parented them the same. And I said, that's exactly what you did wrong because they're two different individuals and they need two different ways in which they need to be parented. And you as a parent not supposed to know that. If your child has diabetes, are you supposed to be born with knowledge of how to treat diabetes in your child? No, you need to come to a doctor and figure it out with them, right? So you're not supposed to know, right?
Yeah.
And unfortunately, we
And
don't
right, what
learn
we're learning is
parenting in
also so
high school.
new.
Huh? What did you
I
say?
said, what we're learning is also so new, right? And
Yes,
so I tell parents that too, like if what we're doing is right new, newish, right? Your research and your treatment, like of course you want to know. Like this is so counterintuitive and hard and really just being able to validate the parents' experience because
absolutely.
they're
It's
having a tough
very, very
time if they're
hard.
coming.
It's so hard. It's so hard. And we're not born being super parents. We're not.
No.
This is something that's learned. Yeah. Well, luckily we know what to do and we have all the available information so people can grab it if they want. So Sam, you said that it's not that much different. Parents first is
Hmm.
applicable here and here. Okay, so I would presume a lot of other things are very similar. What's different? Tell me what's different.
Yeah. What is different is that we are really wanting to focus on the environment. Um, Obviously, we do that in DBT-C with parents first, but also looking at the sensory sensitivities, the learning styles, right? The places where the autistic child needs more support versus less support, what makes things more difficult. And what we want to do is add what we're talking about, those adaptive, not maladaptive
Mhm,
accommodations
mhm,
to the environment. And what we have found is by adding these accommodations up front, um, there's less likelihood of the dysregulation happening where they may even need to use the other skills that we're going to be teaching them, right? Like distress tolerance and um, other skills that are helpful when we're dysregulated because we've helped the environment better fit their neurotype. And working to help them cope when the environment can't fit their neurotype, what
mhm,
they may be
mhm.
able to bring to the table to make it more bearable.
Excellent. Fantastic.
Yeah.
Fantastic. Wonderful. One thing that when you and I were discussing that, we came up to this extension of the metaphor. In DBT-C, we say that children who are emotionally sensitive supersensors, they walk, so to speak, in double gravity, right? They double gravity, yeah, meaning that not only they need to withstand the impact of the stressor, the challenge that comes their way, they also need to withstand the impact of the huge emotional reaction right on top of that stress of double gravity, meaning that both of those things, kind of like double gravity, like walking with your own weight on your shoulders, of course it's going to be very difficult. And what we are offering them is not removing that double gravity. We can't. They will forever ever be emotionally sensitive, right? They will forever ever have this brain that not necessarily is typical, right? And there are pluses and minuses. We don't want to get them away from being neurodiverse and having emotional sensitivity, because it also will take away all the benefits of emotional sensitivity, such as ability to be a human x-ray, ability and enhanced empathy, enhanced creativity, ability to experience positive emotions on a high level as well. Number one, we can't take it away. Number two, it would really be a disaster, right? Because we're taking away the gifts. So they will forever and ever walk in double gravity. What we need to do is give them muscles, emotion regulation muscles, distress tolerant muscles, mindfulness muscles, cognitive restructuring muscles. So they're like bodybuilders of emotion regulation, so they can like withstand the impact of that emotional wave tsunami, like whatever, I can handle it. And what we talked about is yes, super sensors walk in double gravity. Autistic children walk in
Triple.
triple gravity, triple gravity. Because still, even if we do qualify supersensors as neurodiverse, they're still kind of like more in the middle of an average emotionality neurotypical person, autistic person, and our supersensors probably somewhere in the middle between these two worlds. So it's easier for them to navigate in neurotypical world than it would be for children, who are neurodiverse to that end of the spectrum. So of course it's a triple gravity, because also
Exactly.
again we need to continue to remember these children are neurodiverse and they still need to live in neurotypical world
Yep,
and
exactly.
navigate it.
And helping them do that in a way that is, the has the least amount of pain or suffering
Yes,
involved in the long
yes,
run.
yes, yes,
Yeah.
yes. Any other things that you would like to highlight to the audience in terms of, well, number one, so in your experience with children who may indeed have severe functional difficulties navigating your typical world, all of those interventions that we're using in DBT-C with some adaptations and some additions to it, and as you said, most of it is the same. We just need to still, right? Like within like adaptation of DBT-C to different country and different culture, right? The same
Exactly.
thing, right? And this is exactly is what's happening, and people are coming to me, all of those clinicians and researchers that are right now doing research in Latin America, in Norway, and in Israel, all over the world, saying, well, just as you're saying, it's pretty much the same. Of course it's the same because it's human brain, human nature. We just know what we know and we apply what we know in terms of the human nature to help our clients, and they're all humans with some variations in terms of the culture and neurodiversity and stuff like that. So yeah, like let's say like 80-90% of it the same, and then there is some variability that we need to come to and adapt. And with that, all of these adaptations in mind, does it work for children who have significant difficulties in functioning?
So what, again, no research data. Some of our kids come into our clinic with already having an autism diagnosis. Some of them don't, right? And so it's something that through assessment, putting some of the pieces together, we are getting more assessments, right? Having more testing done. And so these kids that are autistic are functioning, right? These are verbal kids. These are kids that may have been misdiagnosed with autism or not, right? And are struggling to navigate the neurotypical world, right? And keeping their emotions, all the sensory input that's coming in. And with these kids and families, we in our clinic have found what we have done with DBT-C and some of the adaptations to have a lot of success. From the changes, from the presenting problems when they come in to where they are now, it's oftentimes worlds of difference, as you have seen in your super sensor family. So tons and tons of success, hoping to get more research data.
If tons of success, if what is kept stable?
Uh,
Parents, parents,
Yep.
parents. Again, we may not even see a client in our treatment room because some children want to come in, or they come in and they're like, I don't know, I don't care, right?
One of my clients, I drew frogs on a whiteboard for 6 months and was working with her mom. And because of all the DBT-C work and the adaptations for the autistic neurotype that we did, so many changes happened before the child learned anything from me or would talk to me. And so that just, yeah.
That's exactly what it is. That's exactly what it is. We don't even need to see a child in therapy. It would be much better. It would be a luxury. We call it child coming into therapy and engaging is a luxury. What is not a luxury, what is an absolute requirement, is parents coming in with an open mind to learn how to parent that particular child, just like you would not know what to do with your child if they had the diagnosis of, I don't know, some kind of physiological disorder, right? You would not know what to do with that, right? So you need to go to a doctor and you need to learn what to do, right? And that, like diabetes, I mentioned before, the same is here. You need to come to an open mind, to therapists with an open mind and say, all right, I know that what I have been doing before, even if it's with the best intentions in mind, even if I read it in a parenting book, even if what my parents did to me and I'm just doing what they did to me and I'm fine, I'm all good and fine. I'm functional. So that must have been an effective way of parenting. We're not disagreeing with any of that. What we're saying is you have an empirical evidence that all of that prior knowledge on parenting somehow does not work with your child. And the empirical evidence of that is you're here talking to me. Otherwise, you would not talk to me, right? So coming with an open mind to learn a different way, which is very hard. And it's also,
and it's really hard because a lot of the families that were definitely not their first stop, right? And so
yes, they
they're
go from,
tired and they're burnt
from
out,
clinician to
you know.
clinician, right? Yeah. Well, listen, before I did my randomized trials and published the research, when was it? 2017, I think, the randomized trial, we didn't know what to do with children who are emotionally sensitive, right? They were misdiagnosed with having bipolar disorder. They were treated with lithium and other, very heavy medications. So, and what we have learned from that research, that we indeed can help these children, emotionally sensitive children, and help them without the use of medications. We can do that. Sometimes we really need medications, but we can do it without it, right? So, and of course we need to do more research on, autism spectrum and how it indeed have an empirical validation. But what you're telling me is that even in cases when the functioning is so interfering with the day-to-day and being able to be adjusted in the neurotypical world, even there we can really help those clients when parents are coming in and learning what needs to be learned, even if the child is not part of treatment.
And then doing it when they go home.
Yes, and they do it when they go home. So I want your confirmation for our audience that this is the same, not only for super sensors, but also for autistic children. Parents are first.
Absolutely. I don't want to say even more so, but just as importantly.
Probably even more importantly.
Yeah.
Because we are talking about triple gravity.
Yep.
And what we're teaching our parents is you need to be the protector for your child, right? And being a protector for your child, you need to know what to do. You need to gain the capacity to do it. You need to not be afraid of your child, like accommodation, tiptoeing around the child, being afraid of outburst. And you cannot make your child afraid of you.
Exactly.
Right? That's like prolonged punishment, severe punishment. So the protective role is amplified for a child who is neurodiverse living in the neurotypical world, because this is like an alien from Mars coming to Earth.
Yep.
How much more protection they would need, right? Adjusting to the earthling type of living. Did I do it any justice by using that metaphor?
I think you use that metaphor even with children in general, right? Like we have to consider
That's so
that
true.
doing anything. And so for me, it doesn't take offense because, I consider even our parents, even when they have made lots of stops and tried lots of things, as aliens from other planets, and not as a bad way, but so that way, like, I don't have these assumptions that they should just know everything, right? And then it makes sense that they don't know things. And so to me, not problematic because of that. And
well, the metaphor of an alien actually comes from my borderline personality disorder, right? Clients with BPD, because they come to me and they say exactly that. I feel like I'm an alien because I don't know how people can just walk around, do shopping and work and do all of that stuff without melting down and getting overwhelmed. So I don't know, I must be an alien. So this is the metaphor that I'm extending to, and this is very hard for anybody who is emotionally sensitive. And we all know that, people with borderline personality disorder are all super sensors, right? Right. And it's very, very hard for them. And it must be so much harder for autistic children, right? Can you tell us specifically in your mind, just briefly, why it would be harder for them? What is it that makes them less capable of just navigating this world?
so every autistic person is going to be different, right? But what we understand is because of the neurodivergence, different learning styles, right?
Different
So
learning
some,
style. Hmm.
right, or learning needs. So really explicit teaching is needed, and that implicit learning isn't always happening or generalization. Really sticky attention. We see that with super sensors too, especially in emotional
And
state.
learning difference as well.
Yes,
Super,
exactly.
you talk about a different brain. Super sensors also have a big comorbidity with learning differences, and it used to be called a learning disability. And I always say it is a disability, but it's a disability of a system,
Yeah,
right?
exactly.
To teach and not typical brain, right? When you're trying to teach typical non-typical brain with typical means, it doesn't work. So we all know that children who have with learning differences, if you give them, if you entrust them into the hands of a person who knows how to teach that brain, they just they just bloom. And
Yep.
it also, learning difference means what? You have different brain, meaning that you're not going to see the world in exactly the same way. Creativity. What is creativity? Being able to see things differently and
Yep.
therefore have different ideas. You can synthesize things in a different way. Creative means not typical.
Exactly.
Yeah. So teach those
Exactly.
children how to teach their own brain, and they're going to indeed go to all the way to the self-actualization of the beauty and the gift of not being average.
And we're also intervening in the environment, not just at home with the parents, but we're coaching and teaching parents how to intervene on other environments so that they support the kid in the way that's their brain's going to learn best or function best when possible. And then helping the kid bring tools to an environment where that's not possible, right? To shape that up. So that way, when these kids are grown-ups, they know what they can ask for and know what works best in a schedule, right? Or right, accepting things that are needed. And so intervening in other places to be able to, like school, right? This is what my kid needs in this place to be able to learn best. Can you help us do that? Right. And so a lot of accommodations are actually also happening in other environments besides just the home, those adaptive accommodations, not the mal.
Absolutely. Oh, thank you so much for making such a difference between them. Because when we talk about accommodation DBT-C, we're talking about tiptoeing around the kid, trying to prevent outbursts, letting them do whatever, to sit on the computer all day long. Of course, I'm extending it, but that's what we mean by accommodation. But again, everything has two sides.
Yep. And we use the word accommodations again because the autistic community, that's their preferred language, and we like to,
Hmm.
use
Right.
preferred language of the community,
Exactly.
even
Just
though
like
it makes it a little confusing. So we just
a
try to
little
clarify.
confusing. Absolutely. But like in standard model DBT, we talk about avoidance.
Hmm.
Avoidance can be adaptive as well.
Yep. Distress
What is
tolerance.
adaptive? Think about distress tolerance skills. All of that is adaptive avoidance, right? How to not make the situation worse, right?
Mhm.
Adaptive avoidance, maladaptive avoidance, adaptive accommodation, maladaptive accommodation, right? So you just always need to qualify, right? This
Yeah.
everything has two sides.
Yeah. And then to finish your question, the other thing that makes the world just, I think, more challenging, or one other thing, there's probably lots of them, is the hypo and hypersensitivity. So being more or less sensitive to all the different senses we have, including proprioception, like the way that we go about the world, and interoception, the way that we experience our body sensations, our touch, the way we sound, right, sight. And so in environments that could, the autistic community uses the spoon theory, right? And talking about
Yes,
how
yes.
we all have a certain number of spoons of energy in our drawer. One of my clients is into tech, and he changed the spoon theory into the bars of a cell phone. And so I thought that was pretty creative.
That's
And
yep,
it,
yep.
if going grocery shopping, for instance, takes me one or two spoons, it may take someone who's autistic several more spoons because of the sounds, because of the clutter they're going to see, because of all the transitions it takes getting in the car, getting out of the car, right? Depending on where their specific struggles are, right? Or
Right.
where their sensory needs are. And so knowing that just getting through life in general can be more difficult. What can we add add tools, accommodations to make it a little less difficult, and teaching you all the other DBT strategies, right? Distress tolerance, emotion regulation,
Mm,
interpersonal
right,
effectiveness
right, right.
to get through too.
Absolutely. And just for our audience who may not be familiar with the term spoons, let me see if I got it correctly. Spoon is how much tolerance you have to stress, right? So let's say you have like a bowl with tolerance, and that bowl has 20 spoons of tolerance, right? That's all you have for the day.
Yep.
And if
Or
you
until you replenish by
or
doing
until
something
you
that you
replenish.
do.
Exactly, exactly. Okay, okay. And what happens once you run out of spoons? Is that when the outburst is happening? What does it mean?
It's way more likely, right? Because
Uh-huh.
if we think about in standard DBT, we always consider vulnerability factors, and we just want to make sure we're considering vulnerability factors even in a bigger way with our
Mhm,
autistic
mhm,
clients and taking it further back, not necessarily the vulnerability factors right in that moment, because they could have decreased spoons earlier in the day, right? And so
mhm,
just really kind
mhm,
of
mhm.
considering that.
Right.
If we're coming to a situation with no tolerance left in our bowl, right, then our window of tolerance on our motion thermometer is much smaller, right? And so then we're going to get into that dysregulation or sometimes just not just, but being more emotionally dysregulated, or sometimes into an autistic meltdown, or
Absolutely.
sometimes emotionally dysregulated into an
And
autistic.
into yes, yes.
Yep.
And just as you said, it's not something that you just come in and you just use. You can replenish it.
Yeah.
Right. And what is replenishment? Like for super sensors, the way that I conceptualize replenishment and I talk about it is that, for example, children with super sensors, a lot of the time, not all the time, but a lot of the time, they can behave really well at school with their friends, kind of like keeping up appearances because I don't want to risk, right? My friends not wanting to be with me. I don't want to risk appearing like different or incapable at school. People think I'm weird, right? But what they're doing is they're holding on for dear life. They're white knuckling it, right? And they're holding on, and then they come home, safe environment. Kudos to your parents for your children freaking out in your house. That means that the environment is safe and the child feels that they can like let it out and they start freaking out sometimes in the car on the way from school
Yep.
to home, right? They open the door. Mom did not even say anything. Child comes in and start freaking out, right? Screaming, yelling. So what's going on? They're releasing it. And because they're suppressing. And when we're teaching them skills, emotional regulation, distress, that's no longer suppression. That we're teaching them a way to release it in a way other than screaming and yelling. Adaptive release versus maladaptive release, right? So and when they release that, that means what? That they're replenishing their tolerance, right?
Yep.
They know they suppress. You can only fit that much. Sooner or later, you need to let it out, right? And when you use skills, it's just not that much that's
Yep.
suppressed, right? There's
Yep.
not that much pressure. So similar what you were talking about, teaching autistic children how to replenish those spoons.
Exactly. And we replenish them on the back end, right? By doing activities that are maybe within your special interest, or rest. Sometimes, being autistically burned out can be confused with looking depressed, and we don't necessarily want to rest. We want behavior activation when we're depressed, and rest for autistic burnout is actually very much needed. And so making sure we have that space between social engagements or whatever the case may be, school. Also, we can work on keeping the spoons in the drawer, or right in the bowl, on the front end by providing those accommodations and support. So loop earbuds, they bring down the sound a lot, and so that has been helpful to a lot of my clients who have a lot of hearing sensitivity. And so, and when it's a loud place, instead of it maybe have taken 10 spoons to get through that, maybe now it's only taking 3, plus their use of emotion regulation skills, distress tolerance, and other strategies that we're teaching them in the moment, right? And so we're
Absolutely.
working on it from both ends.
And also very importantly, differentiating and teaching the environment about the way autistic children relieve stress, not suppress stress. relieve stress, right? Because somebody can do this, somebody can tap, and there is a
Stimming,
specific
yeah.
term for that.
Stimming.
Exactly, exactly. So, and that can be very annoying to other people, number one,
Yep.
like some of them, right?
Can
And
be.
and can indeed be sometimes conceptualized as he's trying to get my nerves, right?
Or destructive, right? Depending on how intense the stim is. And like if
So
you're
can
banging
you
on
give me examples
tables.
of STEM? Right, exactly. Some people will think that this is actually a beginning of the outburst or something else, right? So they may interpret it in a way that is uh, destructive as opposed to what it is, a very constructive way of dealing with overstimulation, right?
Exactly.
So can you
Yeah.
give me examples of stimming?
You gave some good ones, right? Tapping, rubbing your fingers
Okay.
together, playing with your hair, humming. Sometimes stims of, right? They don't annoy the person that's stimming, but they could really be problematic to other people.
Absolutely.
Some more stims that may be more concerning, right? That we might think of as problematic are scratching, right? Even some
What
head
about
banging.
this? What
Yeah,
about,
head
yeah,
banging.
head banging?
Some of the more typical ones to think of people
Rocking,
rocking.
right? Spinning.
Exactly. Yeah.
Mhm.
Really anything that's going is changing the sensory input of what's going on for the child or the individual. And what we want to do is we want them to stim because it's so helpful, right? And we're not teaching them not to stim, and we're helping environments tolerate stims that might be annoying but not destructive, right? That's what we're trying to kind of intervene on the environment to, is accepting the kid you have, and then teaching more adaptive, less
Wait.
destructive
hmm
stims
hmm
when the stim is becoming problematic to the child themselves, right?
hmm hmm
I don't
hmm
like that the problems that it's causing me, or right, I hurt myself. I had a kid that oftentimes banged his the heels of his hands together
hmm
and was hurting him, after he was
I
done.
would
And so
imagine.
we came up when we got a fidget that had some padding to it, and
Yeah.
problem solve that. And so
Uh-huh.
one of my kids currently is stomping, like not marching, pacing, but in a really stomping way, and doesn't want to do it in shoes, afraid that she's going to trip. And so the parents have intervened with the environment to put some mats on the ground, right, to prevent injury. And we are stomping in places that are not going to cause her problems in the long run, right?
And
And so
what does the child do when she needs to relieve that, over, uh, forgot the word,
yep.
overstimulation in the environments when she really cannot do that tapping? What does she do instead? For example, just to give an audience
Yeah, so we
the
find other things. We keep fidgets oftentimes on us. So I in my office I have a huge basket. Not every fidget is preferred by every person, so you get to try them out and then figure out which ones might work better for you. We also practice other things. Would this maybe not work as well, but would this do something that could help you tolerate where you're at, right? Or figure out
Ooh.
maybe
Wait a
what is
second, wait a second. Sam, what you said is very important. So these ways, unless it's hurting the child themselves, right? If it's appropriate at home with people that they know, right, that they can engage in it as much as they need to relieve the overstimulation. In
Yep.
the outside, right, that can cause all kind of social problems that can annoy people. People will looking at you and say, I don't want to be your friend because you're weird. All kind of things can happen. So that can actually hurt the child, even though it's not actually hurting physically the child because of the lack of understanding and acceptance. And in those situations, they can switch to a different way, right? That they can learn and figure out, and they can try different things and see or experiment what works for them. And, or, right, they can learn to accept, let go, and not engage in. Is that indeed possible?
So I think it depends, right? And I think that's sometimes where we're it's great to teach pros and cons, right? Like, what is your goal in this situation? If you need to come
I
out,
love it. In DBT-C, right? You like, because we talked about the method, acceptance, stemming, all of that. It is a method. And I said, is it possible? And you said, wait a second, Francesca. Tell me what's the goal.
yeah,
Then
right?
tell me what's the competing goal. Then select the priority, then accept the other side goal is not going to be, fulfilled. Therefore, so yes, so depending on the goal, of
Right,
course.
like because there's going to be a cost to it. And so if you are not going to stim where that's a place that would be really helpful to you, then there's going to be a big cost when you are out of that environment. And so you may not have anything left in your day. And so if you
Mm-hmm,
have things to
mm-hmm.
do, that may not be an option for you, right? But if your priority is to be there without engaging in your stimming behaviors, right, then we can come up with a plan to try to tolerate that by making sure we're not having anything to do with, right? These are what we're doing with the parents, accommodating. We're not going to go out to dinner afterwards. We're not going to go, right, grocery shopping. We're going straight home, straight to the room, right? Or wherever it may be in order to support that. So we are maybe going to remove them from,
Or
you know,
remove yourself, right? For example, you can be in a social environment, you are engaging in conversation, you are accepting that you have this overstimulation, and you're going on with this, and you may be breathing, maybe doing other techniques to relieve the stress, and then you may actually excuse yourself for a bio break, close the
yeah.
door in the bathroom, and engage in your stemming as much as you need to, and then you come out, right? So all of these things that, of course, requires creativity, requires knowing the child, requires knowing what works and doesn't work, experimenting, trying, and most importantly, what's the goal?
What's
Yes.
the goal?
Anything else that is critically important for you to know before we end that you think that our audience, and especially parents of autistic children, may want to know that we have
I think
not?
it's just some of what we would refer to as like an autistic meltdown over emotion dysregulation is really outside of awareness. And so processing
Mm-hmm.
behaviors, expecting skill use in those situations is probably really unlikely. And so those times we are going to be co-regulating, giving a tool that we know can be sensory reducing,
Mm-hmm.
strongly suggesting, a bath or something else that can be helpful. Again, just to get us out of that meltdown, and then we will be able to use more on brain strategies that are needed for our brain. So during those meltdown, a lot of distress tolerance strategies work, but we can't necessarily expect our kids to access them on their own.
So two questions on what you said. No, three questions. Difference
Great.
between the super sensor, I'm emotionally overwhelmed, I am like under this tsunami meltdown versus autistic meltdown. Second question for audience to know what is co-regulation. And the third one is, so yes, they need to rely in those moments on other people. Can they still learn over time how to catch them? You said outside of awareness, because they need to really rely on themselves at some point, right? Can they increase their mindfulness to the degree of making unconscious conscious? So let's start with the first one, the difference between meltdowns.
Um, so I think so after an autistic meltdown, oftentimes it will be like out of sight, out of mind. So the intensity is not really even felt or understood of what the individual is feeling and the way that they can report back how intense, an emotion dysregulation period
Mm-hmm,
felt.
mm-hmm,
Um, Depending on the individual, we can have almost rapid thoughts during a meltdown or no thoughts. We oftentimes lose the ability to speak, um, or kind of formulate words, process information. And so other strategies might be needed during those times too. And so, doing our emotion waves or a behavior chain with an autistic meltdown is often not helpful because we can't really get what was happening.
Exactly, yes, because it's not conscious. We can only do chains with conscious material. Chain
Exactly.
analysis, like whatever you already know, whatever you are aware of, which is helping the client to put it in the sequence of first that happened, then I felt this, then I said that, then I felt this, then I thought that, I did this, right? So yeah, it's unconscious. So how you, okay, got it. Yeah. So it's question number 2, what is co-regulation?
It's helping someone regulate, right? And so it's using your own regulated self. It's important why our parents have their own good emotion regulation during those periods of time. And it can be literally hugging, holding on, sitting right next to. So we're using our breath to model, right? We're our calm body, that we have found oftentimes is really helpful to autistic individuals, and not expecting them to do it on their own. So when we're patiently waiting or planned ignoring, that may be much more active and close. We're not engaging in problem solving or talking or anything else in that moment, but we are sitting there, we're loving our kid, and we're regulating right with them so they can kind of join into our body.
Wow. And immediately my DBT.
Think about a little baby, right? When they're crying.
Yes. So now immediately my DBT-C therapist, behaviorist mind jumps in and says, wait a second, the child is having a meltdown and you're hugging the child, you're reinforcing the meltdown.
Yeah, so meltdowns aren't behavioral like that, right? And so they're happening outside of that awareness. And so it's not reinforcing the meltdown, it's loving the kid's neurotype you have.
Talking about nothing too extreme. We always say if your child having a meltdown for super sensors, right? Talk about the differences, right? In adapting the model to fit the needs. So if you have a child who is super sensor, not autistic child, it would never be recommended that you hug your child during the meltdown because you're going to reinforce that behavior. However, your child's meltdown is conscious level awareness.
Yep.
Okay. Here we're talking about not conscious level awareness. The child is not fully together, right? And nothing too extreme. There are actually circumstances in which you will hug your child during a meltdown.
And there's times when you're not going to hug your child during a dysregulated moment, an autistic child, because we have assessed the behavior, and some behaviors are do have functions,
Indeed,
right?
instrumental.
Yeah, they're instrumental, right? They've been learned over time, and so it just gets, it's a little tricky, right? And so assessment is always ongoing, and if what we're doing is not working, we go back and reassess, right? And so we must be missing something.
Of course.
Right, and not expect that why isn't the kid just getting it, right? What have we missed?
Absolutely.
Right. And so sometimes we do want to use more planned ignoring with autistic kids, but not during autistic meltdown.
And I just want the audience to know, you see how complicated this is. You see why now, when we talk about DBT-C model, number one, parents first. Number two, the main goal of DBT-C is not actually to make the child fully functional. No. The main goal of DBT-C is to train the parent to become a therapist for their child, not therapists in general, therapists for their child. And treatment ends not when the child is fully functional. Treatment ends when parents know what to do.
Exactly.
Have the capacity to do it. Are no longer afraid of their child, right? They're no longer accommodating. Child is not afraid of them, right? And they have learned sufficient of, the tools of the therapist to continue to understand. You need to match intervention by function. You need to continue to assess the function of the child's behavior. You know how to do this, right? Because treatment is done when the parent has that capacity, meaning that they can just continue to do it on their own.
Yep. And come back when things change.
We're done. See ya. I'll see you maybe once in a while for booster sessions. But other than that, great job. Because these children will continue to have challenges throughout their life, right? I don't want to see that child forever, right? Because they're super sensitive or autistic, with all developmental changes and different, developmental needs. And as they grow in, developmental stages, they will have different challenges. And instead of me continuing to see that child forever, I entrust the parent to know how to do it. And then I just say, all right, now you are a super parent. See ya.
Exactly.
Yeah. Yeah. So there was another question. Is there a way to bring the level of awareness for an autistic individual, be that a child or an adult, to the degree when they are unconscious autistic meltdowns, they can actually manage themselves and be able to catch it and become aware of it?
Yeah, I think that there's a lot of things that we can do, right? But beforehand, right, decreasing those sensory sensitivities, making it less likely we're going to have meltdowns, anyways. Knowing those warning signals and signs within your body when you're getting close, so we can do what is needed, right? Our stop skill, proceed mindfully to decrease the likelihood of a meltdown. And a lot of what we're doing too is hopefully shaping the willingness to get the tools or the strategies within a meltdown. It may not be with an awareness, so we may need an accommodation. So it may be like a meltdown checklist, right? That when we're in meltdown, we're going to go look at it and it says, take a bath, right? And so I'm going to go do it, right? And so we may not actually be able to, once we're in meltdown, get to those things, but we may not always, whether because our family's not around or on vacation, right? Or we're living on our own or whatever it may be able to rely on someone else. So what accommodations can we put in the environment that are going to make it more likely that you're going to be able to get to one of these tools or strategies to decrease the length of time of your meltdown?
Got it.
So it doesn't
Got it. Fantastic. Oh my goodness, this was so helpful. I learned, even though we talked about it many times, even though I obviously know DBT-C, I learned so much from you. And I'm really, really hoping that and I know it will be extremely helpful to our autistic children community and the parents to know that, yes, we can help them. Yes, it can be done.
Yep.
Sam, thank you so much. Any further words of encouragement to our parents of autistic children who may be watching us right now, or parents of super sensors who are watching us right now?
Yeah, well, thank you for having me. I would just say that your easiest day is a lot of parents, your easiest day is a lot of parents' most difficult days. And there are strategies and ways that can help, right? And not necessarily make it easy, but really help.
Yeah, absolutely not. It's not about easy. It will not be easy. It will be hard because we also
love your kid.
Love the kid. And through what we are asking parents to do is reprogram themselves, reprogram how they parent, right? This is hard. This is very hard. And we're not here for quick fixes. Quick fixes don't work. No, they don't. If you want lasting changes, if you don't want to make it worse long term, right? As we always say, parenting is strategic, not tactical.
Yep.
You need to really invest the time and energy in learning how to become that super parent.
Yep. I tell parents there's a cost for everything we want, either up front or on the back end, right? And
yeah,
it's a hard one. And
absolutely. Thank you so much for coming in.
Thank you for having me.
Such a treat. Thank you. Did you like today's discussion? Did you find it helpful? If yes, please like and subscribe. If you're a parent or a clinician and you would like to take some courses with me, please look at the description below. It contains all kind of very useful information. I'm sure I'll see you next week.